Hello and welcome to the next lecture in this series covering the initial assessment of competencies for novice anaesthetists. This talk will cover IAC I02, which is anaesthesia for the spontaneously breathing patient. Our learning objectives for this session include a definition of what a spontaneously breathing anaesthetic might look like, identifying suitable patients and surgical procedures that this type of anaesthetic might be used in. We're going to explore the benefits of allowing a patient to spontaneously ventilate throughout an anaesthetic, discuss the conduct and how we might manage these patients at the beginning, middle and end of an anaesthetic. And lastly, we're going to explore some common complications that might occur, how to avoid, pick up on these, and also manage these if these do occur. We're also going to establish what other curriculum items apart from the IAC code can be linked in order that you can all maximise your work-based place assessments. So the specific sections of the curriculum that we're going to cover is the IAC A02, which is manage anaesthesia for a patient who is not intubated and is breathing spontaneously. So that's the specific IAC code. And below are some other curriculum items that you could work into this work-based place assessment in order to maximise the assessment. It is a good idea to get into the habit of doing this as the curriculum is incredibly vast, and linking in other curriculum domains can enable you to cover these in a single assessment. So just briefly, here is how you can link in these curriculum items. So you can see below where you can add in the IAC code, and the link above where you can link to further curriculum competencies in order to maximise the assessment. So what or who are some spontaneously breathing patients that we are going to look after as anaesthetists? These could be patients undergoing regional anaesthetic techniques, so patients undergoing spinal or epidural anaesthesia, but also patients undergoing peripheral nerve blocks, so axillary, femoral, upper and lower limb blocks. These would all mostly be patients that we might be keeping breathing and awake throughout their procedure. Patients undergoing procedures under sedation are often patients that we at least hope to keep breathing throughout the procedure. This could be used in conjunction with a regional technique, so a peripheral nerve block with a sedation, or a spinal with sedation, or procedures where sedation is used alone. And lastly, we can have patients spontaneously ventilating under general anaesthesia, either for part or the whole of the general anaesthetic. And for the purpose of this talk, we're going to focus on these patients that are spontaneously breathing under GA. When a patient is under a general anaesthetic, they can be put onto a ventilator and ventilated using a mandatory setting. So this is where the machine is doing all of the work. As you will know, this involves using positive pressure ventilation to inflate the patient's lungs, and a rate, volume and/or pressure can be set. Alternatively, under general anaesthetic, a patient can be allowed to breathe for themselves. So this can be unassisted. So this would be a patient that is spontaneously breathing through an anaesthetic circuit without any support of the ventilator. And you'll often hear people saying that this is breathing on the bag. This is because when the patient is breathing through the anaesthetic circuit, you have the visual effect of the bag deflating and inflating with each breath. As there is no ventilator in this circuit, there's no automatic way of augmenting the patient's breathing. But the presence of an APL, or adjustable pressure limiting valve, in the circuit will allow us to deliver some positive end expiratory pressure. If a patient is spontaneously ventilating under general anaesthetic, this can also be assisted. So this is where the patient is initiating breaths, but these are supported either by a ventilator or manually. If this assistance or support is ventilator driven, then the ventilator acts as a pressure generator in series with the respiratory muscles, and the work is shared by the muscles and also the ventilator, resulting in overall the work of breathing for the patient being reduced. This ventilator mode is named differently according to the manufacturer, which can be confusing. Some commonly used names are CPAP PS or CPAP pressure support, CPAP PSV. Combination modes such as synchronized intermittent mandatory ventilation or SIMV, as well as giving mandatory ventilation when needed, do sync with the patient's spontaneous ventilation efforts. Assistance to spontaneous breathing can also be manual. This uses the reservoir bag, as shown in this picture, to augment ventilation. This would be performed by squeezing the reservoir bag in time with the patient's inhalation and releasing it in order to allow them to exhale. This is a key skill as an anaesthetist. So speak to your consultant or whoever's supervising you and make sure you get experience in managing all these different types of patients who are spontaneously breathing under anaesthetic. So unassisted and assisted either through the ventilator or manually. And it's important to note that you really need to get to know the ventilators at your hospital and get to know which type of ventilation mode is the assisted mode for your specific machine. Moving on to sometimes where allowing a patient to breathe spontaneously through an anaesthetic may be inappropriate. So we're going to start off with some patient factors. These include patients who are at a high risk of gastric aspiration. In order to protect the airways of these patients, a cuffed endotracheal tube is generally placed. And in order to ease the placement of this tube, generally muscle relaxants are used, which will mean that this patient will not be a patient that is going to spontaneously breathe for themselves. So I'm not going to go through all the risks that make patients high risk of gastric aspiration, but the common ones are inadequate fasting time, raised BMI, conditions that can result in prolonged gastric emptying time, such as diabetes, severe pain, and pregnancy, and the common things like history of hiatus hernia and personal history of gastroesophageal reflux disease. Another group of patients where it might be inappropriate to allow them to spontaneously breathe are patients where you need a very tight control of the partial pressure of carbon dioxide in their blood, and this includes patients that have suffered a head injury. Carbon dioxide is a potent cerebral vasodilator, and when the partial pressure of carbon dioxide is raised, this increase in blood flow to the brain can increase the intracranial pressure, which can be detrimental to patients who should be neuroprotected because of a head injury. Using a mandatory ventilation mode as opposed to allowing spontaneous ventilation allows us to tightly control the tidal volume in minute ventilation and thus tightly control the partial pressure of carbon dioxide. So using this mandatory mode would generally be necessary in this group of patients. Moving on to some of the surgical factors where allowing spontaneous ventilation might be inappropriate. These include a predicted prolonged surgical time, laparoscopic procedures, intrathoracic surgery, neurosurgical procedures, surgery in different positions, particularly the prone position. This is generally because all of these above surgeries would require the placement of an endotracheal tube. And due to the increased work of breathing that's associated with breathing through a particularly smaller size endotracheal tube, it is not generally considered safe to leave patients breathing spontaneously for a prolonged period of time through an ET tube. The work of breathing is inversely proportional to the size of the endotracheal tube. So particularly in shared airway surgeries such as ENT and max-fac surgeries where very small sized ET tubes might need to be used, this work of breathing can be very, very significant. Lastly, we've included emergency procedures, as these may be groups of patients where they've had an inadequate fasting time, so again a high risk of gastric aspiration, and spontaneous ventilation may be inappropriate, and also the high incidence of acute pain, which as we know can slow gastric emptying. So these are a group of patients where it's maybe inappropriate to allow them to breathe spontaneously. So what are the benefits of allowing a patient to breathe spontaneously throughout a procedure? Or approached a different way, why don't we just mandatorily ventilate all our patients? The main benefit is the avoidance of positive pressure ventilation and all of the negative effects of this, which we will talk through in a later slide. But as with anything in medicine, less is more. And allowing a patient to keep their normal physiology, as opposed to completely reversing it, can only be a good thing for our patients. Maintaining a patient breathing for themselves through an anaesthetic can also enable a faster recovery, as you don't need to kind of get that patient breathing again for themselves at the end of the procedure. It also allows us to use respiratory rate as an indicator of our adequacy and depth of analgesia and anaesthesia, which is a parameter that we completely lose when we're mandatorily ventilating a patient. It is incredibly important to understand the negative effects of positive pressure ventilation as an anaesthetist, and this could be a whole lecture in itself, but we're just going to briefly touch on some of the key negative aspects that can happen as a result of positive pressure ventilation. So within the respiratory system, there is an increase in the amount of atelectasis at the end of the procedure in patients who are positively pressure ventilated. This is due to the way that the gas is distributed amongst the lung, as opposed to when the patient is creating that natural negative pressure inside the thorax. Positive pressure ventilation also leaves patients vulnerable to barotrauma and volutrauma, which can cause pneumothoraces. And overall, patients who are positive pressure ventilated have an increased incidence of post-operative pulmonary complications, so lower respiratory tract infections, and even respiratory failure and acute respiratory distress syndrome. So all reasons why, if possible, it might be better to keep our patients breathing for themselves. Moving on to the cardiovascular system. The positive pressure applied to the thorax during positive pressure ventilation is transmitted to the other structures within the thorax, including the vasculature. Compression of the venous structures results in a reduction in preload to the heart, and thus a reduction in stroke volume and cardiac output. In healthy patients, this doesn't cause too much of an issue, but in patients who are already cardiovascularly unstable or hypovolemic, the effects of this reduction in cardiac output can be significant and cause significant instability. The increase in intrathoracic pressure also causes an increase in the pulmonary vascular resistance, which increases the right ventricular afterload and the right ventricular work, and this results in a reduction in the output coming from the right ventricle also. For the brain, this positive pressure applied to the thorax is transmitted. It impedes venous drainage from the internal and external jugulars and can increase intracranial pressure. Again, this is relatively insignificant for most of our patients, but can. For the gastrointestinal and renal system, when using positive pressure ventilation, particularly through a face mask, or a supraglottic airway, there can be unintended gastric insufflation due to the pressures required to inflate the lungs. Also, this reduction in cardiac output that we see has knock-on effects. For example, it can reduce the perfusion of the kidneys and thus eGFR can fall. There are many other effects of positive pressure ventilation, and we'll post some further reading in the reference slide. One of these being impaired lymphatic drainage due to, again, the increased intrathoracic pressure. Moving on to how we actually conduct anaesthesia for a patient who's breathing spontaneously, we've broken this down into an A, B, C, D structure to try and make this simpler. Airway choice is very important, and a spontaneously breathing patient can be allowed to breathe through a face mask or any of the supraglottic airway devices that we commonly use. We previously discussed why it would be ill-advised to allow a patient to breathe for a prolonged period of time through an endotracheal tube. For breathing, we've already discussed on a previous slide how this can be completely unsupported or supported either manually or through the ventilator. And monitoring for a patient who's spontaneously ventilating is very similar to a patient who we're mandatory ventilating for. So this includes monitoring the respiratory pattern, keeping an eye on the tidal volumes and minute ventilation and ensuring these are adequate for your patient. Clearly monitoring peripheral oxygen saturations is important, and gas monitoring as you would expect for any general anaesthetic. As part of our standard gas monitoring, we will of course be monitoring end tidal concentration of carbon dioxide. This can give us information as to how well the patient is ventilating. As most of the anaesthetic agents and analgesics that we use are respiratory depressants, this can result in a fall in tidal volume and minute ventilation and cause a rise in the end tidal CO2. So it's very important to pay attention to the starting end tidal CO2 for your patient and how that progresses throughout the surgical procedure, as it may mean that your patient needs more support with their breathing. Under circulation, it's much the same as for any general anaesthetic, so adequate IV access and monitoring blood pressure and heart rate as per the AAGBI guidance standards of monitoring. For D, we've got depth. So the anaesthesia plane can be deepened as per other general anaesthetics, so by increasing the flow rate or increasing the inspired concentration of anaesthetic agent. And in a spontaneously breathing anaesthetic, respiratory rate can be used as an indicator of depth. So if you've got a patient that's tachypneic, then this could indicate that they're light and prompt you to deepen the plane of anaesthesia. Lastly, we're going to go through some of the possible complications that can occur during anaesthesia for a patient who's spontaneously breathing. Firstly, tachypnea is a common occurrence when we are looking after a patient who's spontaneously breathing. The first thing we should be doing is looking for a cause of this. So this could be pain or inadequate analgesia, or a inadequate depth or too light anaesthesia. The management of this will depend on the cause, so it could be administrating more analgesics or deepening the plane of anaesthesia. Inadequate tidal volume or minute ventilation can occur due to the fact that most of the anaesthetic agents and analgesics that we use are respiratory depressants and may result in a patient taking inadequate tidal volumes or having a slow respiratory rate. This will be diagnosed through monitoring of the respiratory rate and also through an increase in the end tidal CO2. The management of this can include changing to a assisted mode of ventilation, so changing onto that CPAP pressure support or whatever the mode may be for your ventilator, or assisting with that patient's breathing manually through using the bag. It is important to note that for any patient, our aim is a safe anaesthetic, and that means a safe level of ventilation. So if the end tidal CO2 continues to rise and the patient, though spontaneously breathing, is not breathing effectively enough, there's always the option to take over that patient's breathing completely and change onto a mandatory mode of ventilation. This might involve using a muscle relaxant, depending on the situation. Aspiration is a risk for any patient without a definitive airway at any point in the procedure, or at induction or extubation of a patient with an endotracheal tube. It is our job as anaesthetists to identify these patients who are at risk of aspiration and manage them appropriately, though it is possible that any patient that was considered low risk could aspirate at any point in a procedure. The management of this would be suctioning, clearing the airway and making sure it's clear, and likely exchanging to an endotracheal tube during the procedure with appropriate follow-up. It is possible that any patient that is spontaneously breathing under anaesthetic may become apneic, and there are a number of important causes for this. So obstruction can occur due to the movement of the airway device being used, due to aspiration or due to laryngospasm. Clearly, it is vital that this is picked up on and managed accordingly, as simply changing to a mandatory ventilation mode is not going to fix the issue. The drugs that we give can commonly cause apnea, particularly opiates and or anaesthetic agents. Clearly, the inadvertent administration of a muscle relaxant can also result in apnea. The management of apnea includes treating the cause, be this obstruction, pharmacological or otherwise, and in the meantime, changing to a mandatory ventilation mode or manually mandatory ventilating the patient in order to ensure adequate gas exchange and depth of anaesthesia. Thank you for listening to this presentation. Please, if you can, complete our short survey monkey in order that we can continue to improve our content. You can find a link for this below the video. References and further reading can be found on the final slide.